First of all, I'd like to pay tribute to the first author on this, Mike Stedman. Mike Stedman is an engineer who actually drove the analysis on this paper, and it demonstrates the value of all of us as clinicians or bioscientists actually working with people from different areas, because actually he's done the major analysis for this. If any of you want to contact us, my email address is here, and this paper is now published in International Journal of Clinical Practice in September and is available on PubMed as an abstract as well. Where we're coming from here is to highlight the importance of thinking about blood glucose monitoring strip accuracy. To be honest, before I'd looked at this area, I just thought the blood glucose monitoring strips were all pretty good. Well, the answer is they're not, and there is significant variance in terms of the performance of the blood glucose monitoring strips that are all within the ISO standard, which is the European standard. And what we wanted to do here was to highlight that in terms of doing some modelling using the GP practice data. In other words, how GP practices in England use blood glucose monitoring strips, because there's quite a lot of variability in what blood glucose monitoring strips are used by individual GP practices, and then relate that to the HbA1c for type 1 diabetes patients as available in the National Diabetes Audit. So in this slide here, we've just described the number of type 1 diabetes patients who are included in the analysis. So this is using practice level, not patient level data, but it includes the data on around 160,000 patients with type 1 diabetes and looking at the strips that they use. And I know you can't all see it, but just to say that there's about 5 blood glucose monitoring strips are the main blood glucose monitoring strips used in England. So about 5 take up about 55% of the blood glucose monitoring strips used. When we look at the way that the strips perform, what we've done here is in the brown to describe the highest decile, so those are the best performing strips. In the blue is the kind of median, so that's the middle performing strips in terms of the variability, which is the way that the capillary blood glucose relates to a laboratory reading. The variability can be anything between 5 and 15% on average. But of course that means that for some of the time blood glucose readings may be even further away, and then the green, the lowest decile, so the poorest decile of performance. I just wanted to highlight one thing from this plot, which is that even the best performing strips are only less than 5% away. That's less than 5% away from the laboratory blood glucose for 66% of the time. And the poorest decile of strips are actually only within 5% for less than 50%, about 48% of the time. As you go forward, what we're doing here on the x-axis is we're just getting further and further away from the laboratory blood glucose, and you can see that if we get to 10 to 15% away from the actual laboratory blood glucose, by the way, this is based on peer-reviewed objective analysis of blood glucose monitoring strips, not the company's evidence. So this is looking at studies that have been done. So it's a kind of meta-analysis of the available data, that the poorest performing strips are within 10 and 15%, so quite a long way away from the blood glucose for about 12% of the time. So in other words, there's quite a lot of influence on the way that the blood glucose is measured and the distance from the actual laboratory blood glucose when we actually look at the practice level prescription of those strips. So that's just looking at how at a practice level the strips behave in terms of the average for GP practice and how far away the blood glucose are away from target. So take home message, even the best performing strips used at a GP practice are only on target for about 66% of the time. Here we've related the data for blood glucose variability to National Diabetes Audit HbA1c results, and we've got a linear relation at a GP practice level. So we've taken the average variability for a strip at the GP practice. So practices may use several different strips, and we've taken the average of all of the strips used, then related that to the GP practice performance in terms of HbA1c, and it doesn't change the actual median or mean HbA1c, but as we increase the average variability for the blood glucose strips, so the variability of HbA1c increases. So to put that in a different way, the wider the variation in the blood glucose as measured by the strips, the wider the variance in the HbA1c distribution. So in other words, you're going to have a wider distribution of HbA1c for the type 1 diabetes patients. And finally, just a take-home message, even the best performing strips, according to the evidence that we have, based on the papers that are available, as I not the company evidence, are 2.2 millimoles per mole or more away from the actual laboratory blood glucose on 1 in 20 occasions, and the worst performing strips, and bearing in mind these are all within standard, are 4.5 millimoles per mole or more away from target on 1 in 20 occasions. So to conclude, what we want to highlight with this is please think about the blood glucose monitoring strips that you are using. Some of them are way off target and may actually be supported by your local purchasing authority wherever you're working in Europe because they've struck a deal with the company. Bear in mind also that a lot of patients who are using the better performing strips are still quite a long way from target for some of the time, and that then has an influence on their HbA1c if they have type 1 diabetes, potentially if they have type 2 diabetes as well. So please think about the strips. Thank you, Simon.
Thank you, Adrian. Okay, quick question.